Hi everyone. Again, my name is Ming, and I'm substituting for my supervisor, Dr. Parsons, who, like was said, had a family emergency to take care of today. I just want to say, even though I was contacted last minute, I was very excited to share my experiences, both working with patients as a patient navigator, but also as a veteran of this patient navigation program for the past 2.5 years or so. I'm also very humbled to speak in front of you because I've learned a lot today. I don't know about you, but after hearing all this information from these professionals and experts, I've been more invigorated to work and with my patients and help them get through the care they need. A part of my inspiration for speaking today and also being part of the patient navigation program is, my own personal experience where my mother unfortunately passed away a few years ago of metastatic breast cancer to the lungs. And that has really brought to my foremost attention to really work directly with patients either of minority or who are unable for a variety of reasons to get to the standard of care that's being brought forth in healthcare. And so I hope that today I would share with you just a snapshot of our program and how our patient navigation model works at Tufts Medical Center, but also speak to you about the existence of health disparities in terms of how patients are unable to get through process of care, to get through the care continuum in order to meet those desirable health outcomes. And so certainly our program didn't just arise overnight. It took years of planning, of research, and really understand how or what issues exist within our host community. And so just quickly going back here, our program is in the Tufts Cancer Center, which is part of the medical center in one infrastructure, and we're located in the heart of Chinatown in Boston. And even though there's a lot of gentrification going on, it still very much remains a central hub for a lot of Chinese immigrants that come through. And so our work really began with understanding our host community, understanding what these patients are experiencing, what frustrations or issues they are having while they are getting through their breast cancer care. And through years of formative research with support from various organizations such as the Yaki Foundation and the Asian Healthcare Foundation and the Avon Foundation, we've been able to really conceptualize what our patient navigation program would look like and how we can best care for the patients we serve. And given the standard that's put forth by various policy level organizations, patient navigation is very much recommended to be a central aspect of cancer care overall. And more recently, we've had several scholars at Tufts Medical Center that have received training grants from the Susan G. Komen Foundation to look at how patient navigation affects outcomes and what sort of effectiveness or what impact navigators can have in improving health outcomes for these patients. So just giving you a little bit of background about the patients we serve at Tufts, we actually have, because we are in Chinatown, it's no surprise that a lot of our patients we see who walk through our doors in the cancer center are of Chinese origin. And actually, to our surprise, most of them are of lower socioeconomic status as well. You can see that under the insurance part of our census data, about 93% of our Chinese patients are under some form of subsidized healthcare insurance, and that's mainly like Medicaid, Mass Health, etc. And given the uncertainty of the recent healthcare climate, we expect this demographic to change a lot more too. When we designed our program, we really wanted to meet the needs of patients who are on active treatment. We, of course, realize that there's so much need out there for patients to get through their care across the continuum, but we really wanted to focus our attention on the active treatment phase. With the goals in mind to really improve the timeliness and the quality of care for our minority patients and provide linguistically and culturally appropriate services. As you can see, a lot of our Chinese patients are actually non-English speaking, with 55% of them speaking Cantonese, 22% speaking Mandarin, and actually a surprising 23% speaking less well-known dialects, or what we call regional dialects, that are actually significantly different from Mandarin and Cantonese. What we have found through gathering data about our patients we serve is that a lot of them actually come in already diagnosed with very advanced stage disease. And while that brings into question about screening and prevention, it also brings to light of the extent to which the burden of their disease affects them of getting the healthcare they need and move through the care process. And so that's one thing that I will talk about in this presentation too, is how our program has been able to help support these patients who are already dealing with such high burden illness to get the care they need. So right now we have 3 navigators, myself and 2 of my colleagues, Dachin and Feng Wang. Each of us speak a variety of Chinese dialects. I speak, besides English, Cantonese and Mandarin. Dachin speaks Mandarin and Fukienese, one of the regional dialects, and Feng speaks Mandarin, Cantonese, and Toishanese, another regional dialect. And with this linguistic competency, we've been able to communicate more effectively with the patients we serve. Right now, each of us cares for about 60 patients on average across for each of us, with currently navigating over 200 or so patients in total. But that only is representative of less than 50% of all patients who are quote unquote eligible for our navigation services, which means patients who are on active treatment or of Chinese origin or lower socioeconomic status. So clearly there's a lot of need, and we definitely need more navigators, but right now, just due to resources, we've been only able to cover for about less than 50% of our patients. So our program started really in 2014, and it's been about 2 or 3 years now. And as you can see from this figure, over the course of 3 years, we've navigated over 200 patients, and we've really looked at the volume or the number of patients we've encountered or interacted with across these 3 years. So there's really an exponential growth in the number of encounters we see, and we count these encounters as each patient navigator interaction that's documented in the EMR. Every time a navigator meets with a patient, we document our visit in a note and then upload it into the EMR system in the cancer center so that all of the cancer providers are able to see what we've been doing on the navigator side to help these patients. And so you can see back in 2014, when the program just started, we've only been able to cover lower volumes or lower number of interactions with patients, just because we're sort of figuring out our foothold and figuring out what these patients need, and really building a rapport with the healthcare team. But over the years, we've increased the number of encounters we've had with patients simply due to the fact that, one, we've been able to establish a presence in the cancer center and with the team, so we've become more integrated into the healthcare team itself. So we've been getting a lot more referrals or a lot more contact with the healthcare providers that call or email us and say, hey, the patient is encountering this issue. Would you be able to come in and see what you can do to help out? So I think that all of us in the room can appreciate just how complicated cancer care is, starting from diagnosis through treatment and through either survivorship or during unfortunate circumstances, disease progression or recurrence, or even end-of-life care. But I think that the complexity of cancer care is very much salient in our minds. There's a lot of steps that go on through the whole process, which gives a lot of risk for patients going through this journey, and but also gives a lot of opportunity for whether it's navigators or other healthcare professionals to see what we can do to better support these patients. And so going through just a few of these, in the diagnostic phase, there's a lot of testing that needs to be done, whether it's mammograms or CTs or MRIs. There's just the issue of patients really orienting themselves to the actual physical clinic space. I think it's a very relatable fact that whenever we visit a new clinic or a new hospital, it's really daunting to really figure out where I need to be, or who do I talk to get from A to B, or who do I talk to for advice. There's a lot of medical professionals that you see besides the medical oncologist himself or herself. And also there's a lot of preparation that needs to be done to prepare for treatment if you decide to go on treatment. And through the treatment phase itself, there's a lot that goes in with patients understanding what they're getting, whether it's chemotherapy or radiation or surgery or even endocrine therapy. There's a lot of coordinating of appointments and testing, which can be daunting for patients who especially aren't familiar with the healthcare system or who speak another language and can't really read the appointment sheet that's in English that's provided to them. And there's also a lot of acute issues that go on too if patient is receiving, for example, chemotherapy. There could be a lot of side effects that need managing. And so who do patients go to, especially if they don't speak English, to really address those acute issues that come up when they can't necessarily wait for their next appointment in 2 weeks or a month. And transitioning into these different phases of care after treatment, whether they've become cancer survivors, or if their disease comes back, or if their disease is severe enough that they have to transition into end-of-life care. There's also a lot of cultural nuances that goes on in these types of conversations in terms of understanding, what are these transitions, what do you do now after you've finished treatment, or what does specifically end-of-life care mean, or even palliative care mean to you. And so given all those different steps and all those different risks, it becomes incredibly important to, as a navigator, to really advocate for the patient's needs and their concerns and really understand and build that relationship and utilize that relationship with patients to have these deeper conversations that might not happen otherwise in a clinical setting. And so a lot of what we do is literally attend appointments with patients, go to their medical oncologist appointment or go to their surgical oncologist appointment and be there not only to advocate for the patients, but also get a very good understanding of what the care plan is. And then based on our interactions with the patients and learning what the patient's needs are, then we can better link patients to the resources they need if they encounter any issues, whether it's within the hospital and linking up to nutritional support or helping them figure out where they need to go, to more community-based resources like if they are having issues with insurance or having issues with childcare, or even more complicated topics like immigration, things like that, then we'll be able to point them in the right directions. So just giving you an illustration, a broad illustration of the different types of services we have been providing for our patients. We took data from July through December of last year. And this is just a distribution of the categories of services we have been providing. So on the far left, you can see that our number one service, or our top service that we provide, is some form of language translation, and that's just helping the patients, our Chinese patients who don't speak English, communicate with their healthcare providers, or literally read, things that are in English and translate it for them verbally. Or if they're at home and they need someone to call to address some sort of issue, like, hey, I'm feeling very nauseous, I'm thinking of maybe stopping this medication, like what do I do? Then we'll be able to be that point of contact for those patients too. And that goes into the second category, which is medical liaison. We found that increasingly what we've been doing is, based on the patient's reported issues, is really helping them get through the medical care part. And that includes, understanding or getting their medications, or helping them educate them on their treatment, or even helping the providers if they have something that they need to communicate to the patient or get through to the patient, then we would be their point of contact too. And then going down the list, a lot of appointment coordination, medication management in terms of getting access to the medications they need, whether it's endocrine therapy medications or supportive medications like anti-nausea medication, and helping them understand how to take it, what those medications are, and for how long they should take it. That has been a rising concern for us too. And like I said, just standard wayfinding, like physically getting to where they need to be within a hospital, and instrumental support such as all those social type services that I've mentioned before. We've covered those as well. And so over the years, we've really been able to establish a really good relationship with our care team. And so we're happy to say that we've become more fully integrated into the care team itself. So that really helps in terms of getting timely care for the patients if they have any acute issues that they want to be addressed within a clinical setting, then we'll be able to facilitate that sort of support. And so I want to share with you, just from a patient experience standpoint, it's very much relevant to cancer care. Like I said, there's a lot of things that goes on, and not only in terms of their medical care, but also just how they experience them, attending appointments or getting access to information, or even how they feel communicating with their care providers and their team members. And so we've encountered so many patients who, because of language barriers, either literally can't communicate with the staff. So oftentimes they might just sit in the waiting room for hours and without anyone tending to them. And so some of our patients actually get so frustrated that they leave without even seeing the doctor. There can be long wait times or confusion over when I need to get my blood drawn, where do I go for infusion if I get chemotherapy or radiation, and just the actual physical layout of the clinic can be pretty confusing, especially if the signs are all in English and they can't understand, where to go. But there's also an issue, that's more of a systems resource issue of interpreter services are unfortunately not always reliable, and even if we have that service, they can't always be there for the patients, and so that creates lapses or delays in their communications with their providers. And so all of this put together, if you imagine just a patient who can't speak English, can't speak the native language, and tries to get even to their appointment, there can be a lot of frustrations, or there's simple barriers, system-based barriers that prevent them to getting timely care. And so what we've been able to do on the navigator side is, by meeting with the patients and helping them address these issues, we figured that, what are the interventions that we could make on the systems level in our cancer center to really make life easier for these patients and really to help them get to where they need to be and really reduce that amount of confusion. And so we've been able to implement some physical navigation tools, especially for checking in and checking out, developing a map. We didn't have a map before, so now we have a map for the patients who walk in that are translated, so not only Chinese patients can understand, but also English-speaking patients too. Translated signage like, where is the cancer center? Where is the blood draw station? Where is the infusion center? And making bilingual appointment sheets. Before, we've only had appointment sheets that are in English, and when patients receive that, they have usually a list of 7 different appointments, but they have no idea what they are. But now we're able to, have a bilingual sheet that's in both English and Chinese, so that both our Chinese-speaking and English-speaking patients be able to understand what they're even recommended to getting. And just in terms of timeliness of care, if we think about reducing disparities and reducing mortality rate especially, it's really important that patients get what they need in a timely manner. So I just wanted to share with you 2 specific examples of patients we've met who have either encountered some form of social barrier that has really delayed their timeliness of care, or because of some more medical-based issue that has really created some issues for them in completing their care and continuing their care. So first of all, on the left, I want to share with you a story of a 35-year-old female who speaks Mandarin and was diagnosed with invasive breast cancer. And she was a single mother. She had 2 children to care for, 2 young children. But because of just a lot of insurance instability, she wasn't sure if she could continue getting her chemotherapy. And so at one point she actually declined getting her next cycle, and she said that during a visit to her medical oncologist. But luckily one of our navigators was there, And together they actually figured out, let's not give up yet. Let's figure out if there are some financial resources that we could find to really help you either get some form of insurance or hopefully switch to a different insurance. And so the navigator actually accompanied the patient to financial coordination, which is an office or a service that was not even known to this patient. And meanwhile, the navigator explained the insurance situation to the care team, so they were aware. And together, after meeting with financial coordination and really resolving these insurance issues, the patient was fortunate enough to resume her care and really get the next cycle of chemotherapy. And another story, which is actually a patient of mine who is a 43-year-old female, speaks Mandarin and was diagnosed with DCIS, recently started endocrine therapy. She was prescribed tamoxifen and about a month ago. And about a week and a half in to taking the medication, I received a call from her in the late afternoon, right when I was about to leave work. And she said that, for the past couple of weeks, she's been feeling a lot of weird side effects. And she actually considered, stopping it and waiting until her next appointment, which was not until late April, to then talk to the doctor to see if she could recontinue the medication. And I thought that wasn't right. So I paged the attending physician and told her about what the patient had just told me. And then, after getting advice from the medical oncologist, I called the patient again and told her to not stop the medication, and told her that some of these side effects are expected, that are not unusual for tamoxifen, and that really comforted her, and that really made her feel more comfortable with continuing the medication until her next visit to get her issues addressed. And in terms of medications, recently there's a lot more medications or anti-cancer medications that are more oral-based instead of infusion-based. That coupled with a lot of the supportive medications that some patients get, especially patients who receive chemotherapy for breast cancer, it becomes an increasing burden to keep track of, first of all, what all their medications are and how to take them. And also, as mentioned before, the issues with patient adherence and persistence with medication. There's a lot of risks involved, and that also not only impacts patient safety, whether if they're taking a wrong dose or not, but also impacts eventual health outcome if they're not adhering properly to their medications. And so just another few patient examples I wanted to share from the clinical trial end. We found that one of our patients who was on a clinical trial actually had over a week's worth of leftover pills at the end of a 3-week cycle. And that's a lot of leftover medication for a clinical trial. So that puts the patient at risk not only for being disqualified from the clinical trial if they're not taking it correctly, but also, again, health outcomes. What's going to happen to them on the medical side of how that would impact their success in really treating their disease. And some of our patients, because of some miscommunication, but also of lack of patient education during a visit, believed that an anti-cancer medication was actually an antibiotic. And so she's been taking half the prescribed dose for over a year. And this patient had been coming to the cancer center for a long time, and before our patient navigator program existed, and luckily one of our navigators caught that and was able to resolve that. There's also even simple mix-ups in supportive medications where if a patient's feeling discomfort and they would take a stool softener or an anti-nausea medication to help resolve some of those symptoms associated with anti-cancer medications. And so this particular patient had been complaining for several weeks now of just gas, some pain and constant diarrhea, and he did not know why, she did not know why that has been happening. And so we figured out through talking to this patient and really figuring out her medications that she was on, she actually mixed up the use of a laxative versus a stool softener. And this medication was never really instructed by the care team to the patient on how to take it. And so, that gives an opportunity for a navigator to really intervene and help with the patient education aspect. But also patients, who have been taking the liberty in changing how they take the medications too. That's been an issue that we've seen with our patients. One of my patients had been chopping up 1.5 oxycodone pills after needing a high dose for her pain control. And she did not know that if you chop up pills and sort of take them in different forms, that this could actually decrease how the drug would affect them internally and the bioefficacy of the drug. So a lot of these examples have to do with either a lack of patient understanding or education, or the sort of miscommunication or lack of communication from the care team in really taking the time to support these patients, especially our Chinese patients. So, with the rising concern among our patients and the rising number of issues that we've identified from the navigator, and in terms with regards to medications, we really wanted to work together with the care team, providers, and also with the administration and the cancer center to figure out, is there a systems level initiative that we could implement to really increase patient education, really support their understanding and enhance their understanding, but also hopefully prevent these issues from happening. And so we've first looked at, from 2016 across 162 pharmacy navigator patient interactions, that 75% of those interactions included some form of oral chemotherapy assistance, 23% included medication reconciliation and figuring out what medications patients are taking and if they're actually taking them. And also 24% included getting access to medications. So clearly there's a lot of need within our patient population with regards to this issue about medications. And we wanted to explore further in how we could really make an impact and really resolve these issues and prevent these issues by using patient navigators and supporting these patients. And so we're about to launch this year 2 pilot studies to really first look at logistically, will this work? How will navigators and the care team work together to help these patients and resolve the medication issues? But also what types of educational and support that these patients need to really effectively enhance their understanding and education. What we found that over the years is that as a program, we've really tried to improve the patient experience. And if we think back on the patient who's been waiting in the waiting room for 4 hours with no one to tend to them and they leave without even seeing the doctor, you really helping these patients guide through the actual physical clinic process can be a huge help. I know that it sounds simple, but I think it's these little things that, from a patient standpoint, could really make a huge difference. We've really tried to also improve care retention and adherence, not only with regards to medications, but also if they're getting radiation or surgery or chemotherapy or even endocrine therapy, how are we going to help support them through all of those different treatment processes? And with the integration of our program into the care team itself, we've really been able to bridge the gap of communications between the patients and providers, not only during visits, but also between visits too. And really speaking to that being a bridge or a point of contact between the patients and the providers if anything comes up. And we really hope that at the end of the day, we really equalize the care delivery of all patients, regardless of their race, their culture, or the language they speak. And cancer care is so daunting that with any sort of support we can give to these patients, I think it can make a huge difference. So thank you for having me today, and I hope this was very informational for you.